find there's never a dull moment in this house.
Welcome to Downton.
Downton is catching up with the times we live in.
This calls for a toast.
It plays a trill and a glissando to open George Gershwin's Rhapsody in Blue.
Clarinet.
It is indeed clarinet, correct.
WEIU presents the 2019 Coles County Clash Scholastic Bowl between the Mattoon Green Wave and the Charleston Trojans from the Doudna Fine Arts Center. Who will win this battle of knowledge?
Tune in Wednesday at 6 on WEIU.
From Paris to Taylorville and places in between, City Spotlight focuses on the issues affecting Central and East Central Illinois communities. City Spotlight, Wednesdays at 7 on WEIU.
I wanted to make young people excited about science again. Bill! Nowadays, I'm talking to adults. Climate is changing. We got to get to work on this.
Wow! We are, dare I say it, changing the world!
Tune in Wednesday at 8 on WEIU.
Serving Paris, KZ, and Effingham, WEIU, where you can watch, listen, and learn.
Programming on WEIU is made possible in part by...
I want to keep doing what I love. That's the retirement plan. My annuity, I know there's a guarantee. It's for my family, it's for myself, it's for my future.
Annuities can provide protected income for life. Learn more at retireyourrisk.org.
The Fellowship Center, apartment living for low-income seniors and the disabled, offering an independent living center, monthly social activities, and transportation. The Fellowship Center, 301 Lafayette Avenue East, Mattoon.
Additional funding provided by the generous support from WEIU members like you. Thank you.
Carl is redefining healthcare around you, innovating new solutions and offering all levels of care when and where you need it. Investing in technology and research to optimize healthcare, Carl, with Health Alliance, is always at the forefront to help you thrive.
Meeting the ever-changing healthcare needs of our communities, Paris Community Hospital Family Medical Center is now Horizon Health, with the same ownership, management, providers, and employees. Horizon Health provides patient care and promotes wellness to the communities of East Central Illinois.
At HS St. Anthony's Memorial Hospital, we are at work transforming heart care, rebuilding knees and hips, delivering new generations, and focused on providing health care to you. We are HS St. Anthony's Memorial Hospital.
Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System.
Hi, thank you so much for joining us for this special episode of Being Well this evening. I'm your host, Keanne Armstrong. Advances in orthopedics can seem a little like science fiction, but the more physicians and scientists question the what-ifs, the more innovative they become. Sarah Bush Lincoln orthopedic surgeon Peter Benuti will discuss advances in orthopedic treatment and procedures tonight with us. We are live in the WEIU-TV studio this evening to answer your questions. So please call the number that's at the bottom of your screen, 1-877-727-9348. An operator is standing by to take your call. I will ask your question live on air, and we will get you answers while you're watching this special program. We are also streaming live tonight on Facebook, on YouTube and also WEIU.net. I also have someone making sure that they're keeping up with the post on social media, so if you're asking questions there as well, I'll get those too. So if you're concerned about your voice being on air, it won't be on air. I'll get your message via text and I'll ask it for you. Dr. Brewer was going to join us tonight, and he might, but he's in surgery right now. So if he comes in, we'll get him on the show. But joining me right now is Dr. Peter Benuti, an orthopedic surgeon with Sarah Bush. Thank you so much for joining us tonight.
Thanks for having me.
So this is an interesting topic. I'm hoping we're going to get a lot of questions in this evening. But before we get going on all of those details, why don't you give me a little information about yourself, and then we'll talk about orthopedics in general, and then we'll get into some of the details.
Well, thanks. I'm an orthopedic surgeon, Peter Benuti. I started clinical practice in Effingham, Illinois 30 years ago, so I've been in practice here in Central Illinois for 30 years. We started with an independent clinic, and we've been merged now with Sarah Bush Lincoln. We're proud of the synergies. Over the last 30 years, we started a research and development facility, and we've patented hundreds of medical products and developed technologies that are used now by most of the major medical device companies around the world. So we're proud of that. We're also proud of the fact that we've treated patients from 42 states and 6 countries have come to Central Illinois for their care. So those are positive features and factors that we think show that we too can be innovative here even in Central Illinois.
Yeah, absolutely. And it sounds like there's a lot of innovation that we're going to be talking about this evening, some new things coming to the area, and that's exciting for the people who are watching tonight who may be suffering and thinking, you know, I just don't know about some of these things, and we're here to give them the answers that they're looking for.
Thanks. And they also need to realize that, you know, even though we might be in a smaller community, that we're still able to provide cutting-edge treatments, and we try to stay on the leading edge of medical technology and bring that to patients here in Central Illinois. So I think that's important to realize. You can have confidence that the care you're receiving is as good, we hope, as you'll find anywhere in the country.
Absolutely, especially coming from all those different states and countries, right?
Thank you, yes.
All right, well, thank you for your time this evening. Let's open up the topic and talk about orthopedics in general, and just describe a little bit about what we're going to be talking about tonight.
Well, orthopedics is the study, the science about what we call musculoskeletal disorders, which means injuries of the bones, joints, muscles, ligaments in and around the body. Most of that focuses on the extremities, arms and legs, but it can also include the spine. So we focus on how we repair, treat, and manage those types of injuries. In terms of what we're speaking about tonight, the focus here is looking at how we manage articular cartilage or joint surface injuries, and what's the spectrum of diseases, how can we manage them, from simplest non-surgical treatment to the most complex treatments with robotic surgery. And so I'd like to give general overview and answer questions people may have about what's available, what can be done, or what are options, and give them a focus point so they can research and study more.
Okay, sounds good. Once again, we're taking your questions live on air tonight, and they will be messaged to me. I do have a question that came in the old-fashioned way. I got a letter from a viewer. So she has 2 questions. We'll go ahead and get this answered for you, Diana, from Matt Toon, and then we'll talk a little bit more about some of the other things that you have sitting here on the desk and so forth. So one of her questions is, would it make a torn cartilage on the inside of both knees worse if a person were to get on an inversion bed at a 60-degree angle for 5 minutes, 5 days a week?
Would it damage the joint surface? No, you're actually unloading the joint surface, or by distracting. So an unloader concept is basically using gravity to distract or separate joint surfaces within the body. Some use it for the spine, but you can also use it for joints such as hips and knees, so that if you can put distraction, you separate the joint for a period of time, and many times that can relieve symptoms, pain, and sometimes help with flexibility and motion. So it's a reasonable consideration.
Okay. And her second question is, when there is a tear in the medial
meniscus, or cartilage, yes.
Why is the pain down lower in the tibia?
Yes, why you feel pain down the leg. And part of the first would be the location of the pain. So if we look at the medial meniscus, the knee is just a quick example. There's the femur, the tibia, Inside the joint are two C-shaped shock absorbers called meniscuses or cartilages. They cushion the joint and allow load to be distributed and act as secondary stabilizers to the joint. So her question was the medial meniscus, so in the inner meniscus, sometimes can tear through torsional or twisting injuries. If that meniscus tears, people need to understand there's no blood supply in a meniscus, so there is no intrinsic healing capability. Much like your fingernail, if you tear your fingernail, it doesn't bleed, but it doesn't heal. Now, in some patients, you can deal with that with rest, medications, distraction, bracing, injections sometimes. Sometimes it's too painful for them to continue, and we do procedures to remove that meniscus. So her first question was related, can she get symptomatic relief from distracting the joint or separating the joint? And yes, she can, temporarily, but unfortunately it doesn't cure it. Because the meniscus has no blood supply, there's no real healing potential. So can she live with that injury? Or if it becomes symptomatic, do we require additional treatments? Now, the pain question is, why does it radiate? Well, the meniscus attaches to the bone along the periphery. So when you load this, the body interprets pain radiating down that particular bone. So when you have an injury, you will feel it at the joint and distal going away from that joint. So hip pain, you may feel down the thigh to the knee. Knee injuries, you may feel at the knee radiating down the tibia to the leg. Does that make sense?
Yeah, it does. Yeah, very
explanatory. Hope that answers the question. Sometimes
I hope
you need a
so
problem.
too, Diana. Thank you for sending those questions in. We really appreciate that. We're hoping for more questions tonight. The number's at the bottom of your screen, so be sure to give us a call and I'll ask your question live on air. At what point does someone need to seek medical treatment for joint pain?
Well, that's kind of a challenging question, but from a structural perspective, we recommend people consider an evaluation when they have pain and they have functional disability, which means they really can't do what they want to do because pain is a restriction. Now, sometimes people come for information. They're afraid that what they're doing may be causing further damage, or they want to understand treatment options. But realistically, bottom line is most people try to deal with their symptoms through functional movement, flexibility, strength. They may try some over-the-counter medications. And if they don't help, because they have a functional restriction, means they have pain and they can't do what they want to do, then they come to see us to figure out how they can be helped, improved, or relieve their symptoms.
Okay. Speaking of some of those, I mean, not everything requires surgery, and there's other options for joint pain. What are some of those things?
Absolutely. And the first and the primary treatment is, even though we're surgeons, as orthopedic surgeons, our first goal is to treat you non-surgically, to figure out what your pathology is, so what your problem is, and then how to manage that in non-surgical fashions. So first we'll evaluate the patient. We look at their flexibility, their range of motion. Range of motion and flexibility is critical to resolving many symptomatic joint pain issues. So if you can stretch, learn yoga, learn flexibility, often that's very, very useful. The second is the load that comes across the joint. You know, we're always concerned about patients' weight. Well, as an example around the knee, for every 1 pound of load across the knee, for 1 pound of weight above the knee is 3 pounds extra force across the knee. So if you can lose a little bit of weight, that does decrease the joint reactive forces, so it can symptomatically help those patients. The third then goes into strengthening activities, and whether you develop flexibility, range of motion, but then you have to develop strength. Increasing muscle tone is much like the cables that hold up high-tension power lines. The metal structure is not as important as the cables are and the tension that holds it. So if you want to relieve joint pain, you want to also look at how you strengthen your muscles by tightening these cables. It's not how big your muscles are, it's about resting muscle tone, how tight your muscles are, so that you can develop increased force across the joint to stabilize that, and that can reduce pain as well. So from a non-surgical perspective, flexibility, range of motion, strength are all critical, and we start with those as the hallmarks of treatment.
Okay. Now, you hear a lot of times people getting shots, cortisone shots or different things like that. Talk to me about that, when that comes into play and why somebody might need something like that.
So there's a whole series of injectable type treatments, and basically you can try oral medications, but the challenge with oral medications is that they'll go systemically through your entire body. So if you take a pill and you have a knee problem, for example, that medication will go through your entire body and it's not focused or concentrating at the joint. So one way to think about why we use injections is it can concentrate the medications or treatments right at the site of the problem. So if your knee hurts and you deliver the medicine, you're concentrating it so you may have a better chance. There are a number of injectable treatment options that you can use, and those can vary. The first types of treatment options are things called hyaluronic acid or lubricating injections. Hyaluronic acid is a synthetic lubricant. It comes often from bovine sources, so from cows or animals that's harvested. Some people joke about it coming from rooster combs, but there's a number of different sources. It's a lubricating injection can give inside the joint, and that can help flexibility, range of motion, and sometimes pain relief. Often that's used in early arthritis treatments, and it is a staple of treatment. Hyaluronic acid there's a number of different brands, companies that sell that. The next I'm sure you've heard of is obviously corticosteroids or cortisone injections. Cortisone is given as an analgesic to relieve some pain, but it also is given to reduce inflammation or swelling in the joint. So many times if you have an injury, you have pain in the joint, but you also swell within the joint. That's an indicator that you have problems within the joint, is the amount of swelling in the joint. So cortisone sometimes can be used to decrease some of that inflammation or swelling. So a lot of people will use that often for meniscus tears or for arthritis. That's a common treatment.
Okay.
The next goes more toward biologic type treatment options, and those fall into categories where biologic treatments are segments, or parts, or cells, or sections of body tissue that are used to try and help heal other body tissue. So for example, we can take platelets from the blood. We'll take your own blood, we'll spin the platelets down. There are sections of the blood, there's red blood cells, white blood cells, and the platelets that clot the blood, we can harvest those platelets in concentration, spin them down, centrifuge them, and then inject them in the joints. And they often can have local healing potential for early disease, early damage, and they can help certain patients. We use them also for tendon injuries, for example, tennis elbow, Achilles tendonitis, ligament injuries. For early injuries or partial injuries, they can be useful. The next stage is then, which people hear is called stem cells. Stem cells are either from your own body, they're cells that can differentiate into other type of cells, like cartilage cells. They can differentiate into bone cells. They can differentiate into fibroblasts, for example. And so you take these early cells and you will harvest them, concentrate them, and inject them into the site of the body that has disease or that has pain. And sometimes you will try to use those to heal those body tissues. So in a nutshell, those are kind of the spectrum of most of the analgesics or most of the treatments that we would use as injectables.
So interesting. We've got a question that came in from Mitch and Matt Toon about injections. Now, I'm not going to say all these medical terms right, so I may have you read some of this, but it says, can you talk about injections that replace synovial? Is that right?
Yeah,
Fluids
synovial
in
fluid.
the knee.
That's exactly correct. That's what hyaluronic acid is used for. Inside the knee, unlike most of the body tissue, which is nourished by blood going through your arteries and veins, the knee or any joint in the body doesn't have blood supply. So the cartilage and the tissues in the knee are nourished by synovial fluid. It's a different type of a mechanism that nourishes the joint and also allows for potential healing. So in that synovial fluid are lubricants that the body uses to glide, proteoglycans that allow the joint surfaces to glide smoothly. When the cartilage is injured, obviously there's roughness, there's friction, so you want to reduce that. So hyaluronic acid as a giant category is a category of lubricants that are injected into joints. They're manufactured by a number of different companies that allow you to treat intra-articular or inside the joint injuries, and they effectively nourish the joint by adding lubrication into this synovial fluid, or the fluid that bathes the joint.
Very interesting. You're so precise and very detailed. I love the way that you're explaining all of this information for our viewers tonight. The biologics that you mentioned a minute ago, is that something the insurance covers? How does that work?
Well, biologics, unfortunately, on one hand have been branded a savior or a medical cure-all, but in actuality, the biologics are somewhat challenging in that there's a lot of research that's been done, but it's anecdotal. There's not a lot of big clinical studies, what we call level 1 prospective randomized, really disciplined medical studies that prove if you use this versus this, it's clearly superior in this category. So the problem is a lot of research on stem cells, a lot of anecdotal work. There's not a lot of prospective top-level studies like you would use, for example, to launch a pharmaceutical like a medication. So because of these, the insurance companies are somewhat balking at the success, reliability, efficacy, how well they're useful. So they're balking at payments. So most of the biologics really are struggling with obtaining insurance clearance. So many patients have to pay these out of pocket, and they can be rather expensive. Some of the injections, like hyaluronic acids, for example, they can be $600 an injection on the low side. Insurance companies often cover them. On the high side, platelets can be $2,000 for an injection. Some stem cells, the autogenous, where you harvested from your own bone marrow, for example, can be as much as $5,000 for an injection. And since insurance carriers don't cover it, patients have to pay out of pocket, and it can be quite expensive. It's not to say they don't work. It's to simply say you have to note to patients that they'll be fighting an uphill battle if they try to submit it to insurance. Be aware that they may have to pay out of pocket. There are some advantages to them, but they are expensive.
Okay. Are there side effects to the biologics?
Well, the biologics, the first would be the risk that the harvesting, if you're harvesting it from yourself, can you get a reaction from the harvest site? Very uncommon. Second is when you inject in the joint, can they get bleeding or a localized reaction to that? Sometimes the injection can bleed into the tissue, can cause local inflammation for 2, 3, 5 days. That can be uncomfortable. And then the last is if you have xenografts or allografts where stem cells are from other patients, you can sometimes get allergic reactions to those because they're foreign proteins, foreign agents. So it's rare that that occurs, but you can get significant allergic reactions sometimes where the joint will swell, become very painful for a week or two. So those rare, but they can occur.
Okay. Do you think that maybe down the road biologics may eliminate the need for surgery? Do you think that that's...
the big challenge is catching the diseases early enough that a biologics have a chance to heal. Many of our diagnostic techniques, X-rays only see more advanced disease, CAT scans look at bony abnormalities, MRIs that we use to look at tissue cartilage often don't catch early disease processes. And so if the bone itself has become damaged, then there's much less chance that the biologics will be efficacious or helpful. Because once the bone is diseased, you got to treat the bone as well as the cartilage as well as the joint. So the trick with the biologics is to catch the disease early enough that they can be effective. Okay. And that's sometimes challenging.
All right. Let's see. I've got a question here from Marcy in Charleston. She has to have a hip replacement but has metal allergies. What are your suggestions?
For hip replacements, well, let's start first. Metal allergies are some of our more challenging things in orthopedics. We use a lot of metal for fixing fractures, fixing joints, and so metal has been used in the body for hundreds of years. Certain patients have certain allergies to metal-based substrates, meaning nickel. People talk about wearing bad jewelry and then they get reactions to it. But the reactions to jewelry or superficial issues on the skin don't always equate or equilibrate to what happens inside the body. So even though you might react to something on the surface of your skin reaction and deep body tissue reaction are different. But you can have allergies and you can get those reactions within a joint. There are certain tests that we perform to allow you to, number one, check for that. Two, if the patient has an allergy, especially on the hip side, it's relatively straightforward to treat that because most implants now are made of titanium on the shell and on the stem. So if we were to do a hip replacement, if she has a question about that, I'll just use a prop here. I hope this helps. But
sure.
This is a hip replacement, and not all of the hip replacement is made out of metal. The stem is made out of metal. Typically, this is titanium. Very low risk of allergy to titanium. There's no nickel in it, for example. On the acetabular side, there is a socket. The socket is also made out of titanium. The bone grows into these surfaces, and that's very low risk of metal allergies. So titanium is very low risk for metal allergies. Where the allergies used to come from was what's called the femoral head, or the ball of the hip joint. This used to be made out of a material called cobalt chrome. Cobalt chrome does have some nickel, and there are occasionally some patients that have allergies to that. But recently, people have gone to more ceramic surfaces for the hip. So if you apply a ceramic surface to this titanium stem, then there's a very low risk of any type of allergic response because those don't contain nickel or cobalt or chromium. So by eliminating those materials, reduces the risk of allergic responses in and around the hip.
Okay.
I hope that helps. But on a hip replacement, on a knee replacement, that's a different issue. But on a hip replacement, that's if you treat it with those, it's a very straightforward way to manage any type of allergic response. I say that risk is very low.
All righty. Thank you so much for answering that.
Sure.
Marcy, thank you for asking that question. We have another question here from Janice from Mattoon. Please discuss knee replacement and the recovery therapy needed for specifically knee and joint replacement. And we're going to get into surgical options after the break, but let's go ahead and answer this question and get that answer over to Janice and Mattoon.
So the question was specifically related to recovery?
Please discuss knee replacement and the recovery therapy needed specifically for knee and joint replacement.
Okay, let's focus on knee replacements. That's actually the most common joint that's replaced worldwide. There are more knee replacements performed than any other arthroplasty. For example, there's about 100,000 more knee replacements done than hip replacements in the U.S., and about 10 times more than shoulder or other joints are replaced. So knee replacement is most common. The challenge with knee replacements is, as she brought up, the recovery. How quickly can you recover and get back to normal functional activity? So there's really high stresses that go across the knee joint. The joint has to work through a 130-degree arc of motion. So the muscles have to fire, the joint has to work through that motion. So it's challenging. So first, with knee replacements, you got to start walking, weight bearing. We have changed over the last decade, going from starting therapy the first or second day after surgery to starting immediate full weight bearing. Typically within an hour to 2 hours after surgery, we have our patients walking full weight bearing. That has been in part facilitated by new techniques, but also by some analgesic techniques from anesthesia and pain blocks that allow you basically to get rid of some of the early pain and allow movement. And it's critical to get weight bearing and movement early because your recovery is faster. So the faster you start your rehabilitation, the faster you recover. So first, starting weight bearing. Phase 2, you really got to get your flexibility back. Bad English, got to get, but you have to restore flexibility and range of motion. That means you have to get your knee fully extended and flexed to getting that function back. Because if your knee is stiff, you'll have trouble with sitting, climbing stairs, kneeling, crawling, squatting. So a lot of functional activity in the knee require range of motion. So first, weight bearing. Second, range of motion. Third, you have to work yourself off of appliances, meaning a cane or a walker, and that's by getting your strength back. And the last is endurance, trying to repetitively get back to your normal activities, whether it's working, farming, housekeeping, so that you get back to your normal lifestyle. So there's kind of a three-phased approach we use, and that rehabilitation early phase, work in flexibility, range of motion, we do that for the first 2 to 4 weeks. Functional strength, we start really right after surgery, can take about 6 weeks, and then endurance, repetitive activity, can take anywhere from 6 to 12 weeks to really get normal with your joints. So looking at, let's say, driving a car, you might be driving a car within a couple weeks. Getting back to work for most light-duty activities, 4 to 6 weeks. It can take, if you're a heavy construction worker, heavy farmer, it may take anywhere from 6 to 12 weeks to get all your strength and functional improvement back. So I kind of hope that answers your question, kind of giving you a rough timeline. Obviously, it varies on how strong you were before surgery. So the stronger, the more flexible, the better you are before surgery, the quicker your recovery is afterward. So that's also a variable. And so we work on that as well by teaching prehabilitation or recovery before surgery, which is critical.
Okay, sounds good. I'm going to ask one more question, then we're going to go to a short break, and then I think we've got some videos and some other things that we want to talk about as far as surgery options and different things like that, the robotic treatments and things like that. So Let me ask this question, then we'll go to a break, and then we'll come back and discuss all of that. I have Mac from Matt Toon. Is a person with arthritis more susceptible for joint damage, and if so, are there any prevention methods?
By arthritis, you're already telling us that there is joint damage that exists. So if someone has joint damage, means that the articular cartilage or the smooth surface around the joint has already been injured, roughened, much like we will see here. So these are different phases, but in advanced disease, you start to lose the cartilage surface and you get these red uneven surfaces. This is a schematic indication of damage to the joint. So in a nutshell, if you have damage to your joint already, yes, that will progress based on movement function. So the question is, how can you provide longevity to that, or how can you extend the life of your joint once it's already damaged? And those, again, regard to how do you improve flexibility. Range of motion, again, becomes the most key issue. The more flexible your joint is, the less pain, the better your function is, even if you have disease. Second, building up tone, not necessarily bulk, not how big you are, but how you develop tone so that you get around the joint. Third is decreasing the load across your joint, so modify your activities. If you like to run, for example, you may need to change to doing elliptical trainers or aquatherapy or bicycles to decrease the load across your joint, to find activities that build strength but don't irritate or damage the joint. And some of that is by you following your joint from pain, swelling, and making sure that you keep that flexibility. So those are three. And then last is decreasing weight across the joint. That always is a very useful factor, because decreasing the load, whether it's through your weight or through the types of activity you do, can help preserve that joint and improve function.
All right, sounds good. Thank you for answering those. And I want to thank you for calling in and asking your questions tonight. We're going to take a short break and we'll be right back. So if you have more questions, we'll be back to answer them in just a moment. Stay tuned, don't go anywhere.
Starting Tuesday, September 17th at 7 on WEIU, begins another season of Being Well. Season 12 of Being Well will feature 16 episodes with medical experts from across Central Illinois, discussing topics such as nutrition and weight management, bariatric surgery, breast disease, diabetes prevention, and virtual health. It's Season 12 of Being Well, starting September 17th on WEIU.
Hi, my name is Helen Shores.
My name is Bob Blade.
I'm Vivian Hallett.
Hi, my name is Rex Lindley.
My name is Carolyn Shull.
I'm John Barger.
My name is Jeannie Cruz.
I'm G. Stanley Alden.
Hi, my name is Carol Jo Fritz.
My name is Jim Whitaker.
Hi, my name is Kathy Clayball.
My name is Charles Logan McKinney.
My name is Marlene Van Meter.
I'm Roger Anderson.
Hello, I'm Mary Hill Dobbs.
Hi, my name is Sarah Dow.
Hi, my name is David Cameron.
My name is Dorothy Redsock.
Hi, my name is Evelyn Sue Eisnagel.
My name is Larry Stoltz.
I'm Peggy Short Stuntz.
Hi, my name is Billy Chambers.
My name is Gene Nichols.
Hi, my name is Karen Lindley.
My name is Linda Matherly.
I'm Millie Lee Stewart.
My name is Mike Rice.
Hi, my name is Tanya Craig.
My name is Brenda Jones. Be sure to watch Cumberland County. This is our story right here on WEIU.
And we're back with a live edition of Being Well this evening, and we're talking about orthopedics, joint replacement, partial knee replacement, total hip replacement, and I have Dr. Peter Benuti here with Sarah Bush Lincoln tonight, and we've been answering your questions live on air, and we've got more coming in. We're also streaming live on YouTube, Facebook, and WEIU.net website, so if you are posting online, we're getting those messages as well. So the numbers at the bottom of your screen, we want to get the answers for you, so keep them coming. Before we get into the surgical options, which I said we were going to do, I have a question from Joy in Mattoon. She's had both knees replaced. Left knee was operated on 4 times, the right 3 times. She's in a wheelchair and wants to know if there are any procedures to be performed to allow her to get out of her wheelchair.
There are always opportunities to improve diseased or damaged bones or tissues. Unfortunately, we'd have to understand through x-rays and some diagnostic testing what was previously done and what the current status of her bone is, her ligaments, and the muscle around her joints. If she, depending on the stability of those, we can design different types of surgical procedures. Can she get full function back, partial function? But clearly, yes, there are always options to improve function, but it would require a little more in-depth analysis of what the disease is and how it's been treated so far and what her residual ligament, bone, muscle structure is to tailor something specifically for her.
All right, sounds good. Thank you, Joy, for asking that question. Now let's talk about some of the surgical options that may be new to the area, some different things that we've got some video clips to show some of our viewers tonight. So I want you to lead us through some of the options that may be new, some of your different things that you have here to show people and illustrate what you're doing, and maybe get some of this information out to our viewers that they don't know is around this area yet.
Well, thanks. Well, first, I think we'd like to talk maybe about partial knee replacement, or some people argue it's called segmental knee replacement. So a knee, if you break it apart, is really based on 3 separate compartments. Maybe we can use a different model. But if we look at a knee, we will see that a knee is basically, there's a femoral component, there's a femur, a tibia, and there's also a patella or kneecap component. So when you break the knee up, we think about that as 3 separate segments or 3 separate compartments. And the knee can wear or become damaged in one or multiple of those compartments. Some of that can be traumatic in etiology or nature. Some of it can be from injury, or some can be from genetics. You're born bow-legged or knock-kneed that can predispose you for the knee joint wearing. So we need to understand what the disease process is, where it's located. So just like we talked about biologics, if we can capture the disease early, there may be biologic treatment options either through injections or even some where we can apply biologics with scaffolds to repair small defects. but most often we catch them, unfortunately, when you have more substantial damage and where the joint is worn or damaged, past the point where biologics will help you, or where we have full thickness loss, where you have bone rubbing against bone. So then we decide to isolate where that is. Is the pain generator where they're having problems in the kneecap? Is it on the lateral outside part of the knee? Is it on the inside? And then what's the deformity? Do they have ligament deformity as well, where they're bow-legged or knock-kneed, where the ligaments are also diseased as well as the tissue? Once we can figure out where the pain is coming from, where the deformity is, we can in early stages do what's called segmental or partial knee replacements. So if the kneecap is worn, for example, we can do isolated patellofemoral replacement. We replace this portion of the femur called the trochlea, and then we replace a portion of the kneecap. As we will see it, this is a total knee model, but we would replace it with a similar type of kneecap here. So you would replace the kneecap as well as the trochlear groove if that is the only area of disease. Now, the most common area of disease is most people have a varus or bow-legged deformity, and they tend to wear on the inside of the knee. So if the knee wears on the femur and tibia, we can do something called a partial or medial knee replacement, where we're just replacing the inside part of the knee. The beauty of these type of procedures is it maintains the other parts of your knee. It maintains the ligaments in your knee, maintains the opposite part of your knee, so it feels more like your own knee. It feels relatively normal because you've only replaced part of your knee. And we can do that the medial compartment, the patellofemoral or kneecap compartment, or the lateral or outside compartment can be replaced step by step. Okay. If the disease involves 2 or more compartments, sometimes that would lead us to a total knee replacement where we replace the entire surface. And so in a total knee replacement, what we're doing is replacing all 3 components to the knee. We replace the femur by machining off 8 millimeters of bone and cartilage to reshape the femur and put a femoral component. We take 8 to 10 millimeters of tibial bone off and replace it with a tibial component. And then we balance that with a plastic spacer called polyethylene that allows us to adjust for the ligaments and to get better range of motion. And then we can resurface the kneecap or patella, where we leave part of your kneecap and replace part of the patella surface, so you have plastic rubbing against metal, which gives a better joint surface or better reaction. So these are the treatment options that we can use as what we call joint replacement or arthroplasty around the knee.
All right, that's really cool to see that in model form. Now, do you want to go ahead and run some of the video clips that we have and then talk about those? Do you want to start with the partial knee replacement?
Yes, so the video clips will relate quickly just to about robotic use, and these are some of the newer technologies. So again, here this video shows the knee is made of 3 compartments as we described, and you can have wear in one or multiple of these compartments. So if we can diagnose that one compartment versus another is damaged, we would replace it. That would be a total knee when multiple compartments are diseased. So in earlier stages where only one compartment is diseased or damaged, we can consider something called a partial knee replacement. And in a partial knee replacement, basically it's a smaller segment of the joints replaced, so a minimal area of metal and plastic to remove that diseased area. But the challenge with that is we need precision, because we need to make sure that the ligaments and the other sides of the joint are balanced properly so everything aligns. So this is where Mako and robotic surgery took its hold initially in orthopedics, where we're able to take the precision using a CAT scan before surgery to determine the abnormality, the disease, and the amount of disease, line that up to set us how we're going to correct the joint back to where it should be using the preoperative CAT scan. Then that creates a model that we use before surgery, tells us what size joint we should use and where our bone cuts should be. So we have the disease analysis through the CAT scan. We map these out preoperatively so the surgeon knows exactly what size and what areas need to be replaced. And with this preoperative plan, the surgeon can then take that and start to mold this in surgery. So during surgery, then, we use this topical pointer that allows us to map out the joint surface so that we have now the living anatomy versus the preoperative CAT scan. It allows us to map out the deformity that you have. And then with that, it allows us to bring a haptic or robotic system, which the surgeon controls, to make the appropriate bone cuts. In this video, we're showing how we map out the deformity of the knee, and then this has to be matched to the CAT scan. Then we bring in the robotic system. It's a haptic system. The surgeon actually drives it. This has boundary or barrier layers, so the burr cannot go, or the saw cannot go past certain areas. It allows us to precisely correct the deformity, in this case on the femur. So this is the femoral cuts that we would use, and here we're using a burr to make those cuts, and then we will make the similar cuts on the tibia, And that precisely within up to 1/10 of a degree allows us to correct the alignment and then put the appropriate joint and ligament balancing into this knee so that we get good range of motion function. With these patients, we have them weight bearing literally an hour after surgery, and our patients go home between 2 and 3 hours. So we do this on an outpatient basis, and the patients are functional active. That day, they walk out with a cane in 95% of the cases. We've actually done some bilaterals, so with partial knees, we can do bilaterals, and they go home the same day as well.
That's remarkable.
So some of the new technologies, both from the surgery and from our anesthesia and pain approaches, allow us to get patients moving that day.
Yeah, that's remarkable.
Thanks.
Outpatient surgery for partial knee replacement.
Yes, ma'am.
So we also have an explanation video that you're going to go through for total knee replacement.
Yes.
Go through that and tell us the difference between that versus the partial. Since we just got the partial, let's go through total so those people who have this problem, they can get that information as well. So
Sure.
we've got a video clip here for total knee replacement.
So here in the total knee, you're showing that the deformity where the cartilage in all 3 parts of your knee is damaged and eroded. In a traditional total knee, you make 5 cuts on the femur, the upper bone, 1 cut on the tibia with a keel, and you align and replace this with manual instruments that basically use the inside of the femoral bone and the tibia to align the knee and correct it. With the Mako system and the robotic system, what we do is we base this on a preoperative CAT scan again, just like the partial knee. The preoperative CAT scan gives us the alignment and the precision of what the deformity is and planning it out to what the correction be, not just of the bone, but of the ligaments, so that we can balance the knee so it's stable through motion and also that you get the high flexibility and function out of this. Once again, we have to map out the joint surface. So after the CAT scan, during surgery, we map out the joint surface. We balance the ligaments by aligning the CAT scan as well as the plan so that we can get the range of motion and function. So you have a knee, but you don't want a stiff knee. You need to have something that fully moves, fully articulates, so you have a better range of motion or functional activity. In this situation, we use an oscillating saw that goes back and forth quickly rather than a burr, to make these 5 cuts on the femur and the 1 cut on the tibia that allows you to line this and make those cuts. And these again are done precisely without any cutting jigs or cutting blocks, so there's no metal debris, there's no damage, and it protects the tissue because the oscillating saw and the robot have what's called haptic barriers, so prevent the surgeon from injuring any other ligaments or tissues around the joint. And then we cap the joint surface and replace it. This is the Mako robotic system, and a robot, it's really haptic. The surgeon drives it, the surgeon controls it, but it has strong barriers and endpoints that protect the rest of the tissue and allow us to do this in a very efficient and precise fashion.
Very cool. That's really neat to see those videos. I think the viewers at home will appreciate that, to see exactly how that's done, what it looks like, and so forth. We've got a question from Jeff from Windsor,
Sure.
And he has had full knee replacement, but he's in a lot of pain. He learned that the implant pulled away from the upper leg bone and will have to have it redone. He was wondering, hold on, I'm getting a call here.
No problem.
He was wondering if Sarah Bush has robotics that would help avoid a long recovery.
Yes, robotics unfortunately are not functional yet for revision knee replacements, which replacing a knee that's already been replaced, because there are long-term issues with alignment and regulatory issues with the government. But there is the technology, it exists, but it's not available today due to the regulatory pathways. However, robotics are available for primary knee surgery for knee replacement, not revision knee replacement. Does robotic surgery have a chance to improve or decrease the risk of what he's talking about, which is debonding or loosening of the implant? Yes, if it's applied more precisely in line, it should increase longevity or how long the implant will last. So it does have better potential for that. Now, in his situation where the implant is debonded or separated, usually that's bone cement separating from the bone. And yes, once that bone cement shifts or starts to move and that implant is loose and wiggles, it has to be replaced because it creates swelling, it creates pain, and over time it destroys bone further. So once that implant loosens, it does need to be revised and replaced. That leads us to something else we can do off of robotics and with some of the new technology, and that's something called the cementless joint replacement, where rather than using a bone cement to grout the implant in position, we now are able, like a hip replacement, to make it cementless, where the bone actually grows into the surface. And in those situations, you decrease that risk of this implant debonding or separating from the bone downstream, because once the bone grows into the metal, it becomes part of the body and obviously stable for the rest of your life because it's well ingrown or fixed. So cementless technology is another iteration of new technologies we have available that either independent or linked with robotics gives you the best chance, I think, for young active patients to get the best long-term results.
All right, thank you, Jeff. We hope that that answered your question. Thank you for calling from Windsor. You mentioned hip replacement. Let's get into that in just a minute, but before you go there, I've heard of something called tourniquet-free surgery. Is that what we're talking about, or is that something different?
Tourniquet-free surgery is something a little different. Basically, during surgical procedure on a knee, to enhance the visualization and decrease the risk of blood loss, we'll put a tourniquet around the thigh, just like a blood pressure cuff, but you would have put that around the thigh during surgery. And if you can imagine your blood pressure cuff, if you left it on your arm for 5, 10, 15 minutes, it can be painful.
Yeah.
So, and it can also affect the muscle function after surgery. So we use tourniquets to do many knee replacement surgeries. That's pretty much the standard of care because it stops the bleeding so that during surgery we can see all the bone, the ligaments, and do the surgery efficiently. It was used a lot because when you used bone cement to hold the implant in position to grout it, you needed a clean, dry surface so the bone cement would not adhere, so the implant would fail. So you'd put the tourniquet up to do the surgery when you needed a bone cement or a grouting agent. When you go to cementless surgery, we're using an ingrowth implant where the bone grows in the implant. You do not need that quite dry environment. So you can go to something called a tourniquet-less surgery where you're not using the tourniquet at all to do the procedure, and that some people feel gets less pain and faster recovery. In our experience, we published a study on it, and it shows that we can, using the tourniquet decreases the blood loss. The patients for the first day feel better, but we did not see long-term differences. But patients can recover a little bit quicker without a tourniquet use. It is a subtle factor, but it can be useful. The problem is it does increase the surgery time, and it does increase the risk of bleeding around surgery. So there's a trade-off there. There's no long-term data that shows it makes any difference, however, for patients 1 month, 6 months, 12 months downstream.
Okay, thank you for that explanation. I want to get to hip replacement. We've got, 10, 12 minutes left in the show, but before we get to that and show the video on the hip replacement, Peggy from Jacksonville says both knees need replaced and her kneecaps are bent out of shape. Would replacement affect muscles, and would fixing one kneecap at a time affect balance?
Well, let's start. The first question, can she benefit from surgery? Yes, if she has deformity. Obviously, I haven't seen her x-rays, but yes, if she has deformity of the bones and she has pain, functional disability, yes, we can improve her with a joint replacement, with a knee replacement. Second of all, does it affect muscle function? Yes, and when you do the surgery, if you cut into the tendons and muscles to do the surgery through standard approaches and you dislocate the joint during that, you can affect muscles and ligaments, and sometimes that delays recovery. So if you can avoid cutting into the muscle, reduce the muscle damage during surgery, they will recover faster. One idea is trying to not use a tourniquet. Less important. Second is avoiding cutting into the muscle or into the quadriceps tendon, doing things called subvastus approaches or sparing approaches seem to have some short-term as well as potential long-term benefit so that the patients can return to their prior strength. So we want the patients not only to get better than they were before surgery, but enhance the muscle strength. So limiting the muscle exposure has that potential to make that patient functionally return long-term at a better stage than if they were injuring the muscle during the procedure. So that's the goal, is trying to get patients to quicker and normal function and high activity.
Sounds good. We've got about 10 minutes left. Let's get into the hip replacement. I want to make sure that folks see that. Give an explanation of your model that you have here, and then we'll go into the video so we can get that out to the viewers as well.
Sure. So a hip replacement, a knee replacement really isn't truly a replacement. Basically, it's more like resurfacing a procedure. You're retreading a tire of a car, for example. But a hip replacement really is a replacement where you are taking the bone, cutting the femoral head off, removing that. So this is truly a replacement. You're removing the ball, and then you're replacing that with a stem, a femoral head, and an acetabulum or socket. So you effectively have a ball and socket joint. It's much simpler from a mechanical perspective than knee replacement, because a knee replacement is 3 separate joints. A hip replacement is a single joint, but hip replacements are also challenging in terms of their alignment and position so that they're stable after surgery and that the implants are positioned properly, because they're very deep in the body and you don't use a tourniquet. So with a hip replacement, you always have to watch for visibility and visualization. So again, there are components. There's an acetabulum or socket component. Typically the bone grows into the metal. There is a plastic liner called polyethylene that gives you the flexibility and the movement. There is a femoral head component that allows us to adjust the size and the ligament tension, the tightness. And there's the femoral stem, which sits inside the bone. Bone grows this to give us the stability and ingrowth around the femoral component. So these are the components of a hip replacement. And these can be done through, again, manual instruments, which have been done for nearly a century now. And we've evolved that to looking at robotics type technology to reduce some of the complications and possibly increase the speed of recovery after surgery. So robotics have been promoted for that and can help some, especially with ligament tension, alignment, dislocation, leg length, so that you can optimize some of those parameters, and robots give you that potential.
All right, well, let's go ahead and roll that video so folks can see what the hip replacement looks like, and you can explain that as they see that on screen as well. So there we go.
So this is the Mako system, and what you're seeing there is the acetabular reamer. This preoperatively, again, we use CAT scans to give us that alignment and position, so we know what the disease is, we know what the deformity is, we know what the opposite leg does, so that we can make the leg length symmetric, balance the hip, and make sure it's as stable as we possibly can. So here we're showing how we look at the anatomy, we look at the deformity, we map out the joint surface just like a knee replacement, so we know where we are in the CAT scan. Now we map this out during surgery so we know where the parts are in the body relative to the CAT scan. Then we will bring in, make a saw to cut the femoral stem as we showed, and then we map out the socket. This is the most complex side of this because the socket often is deformed, and so we need to map out your normal anatomy. From the preoperative CAT scan, we know where the deformity is, and then it helps us to allow to correct it so that we can remove the appropriate bone remedially to create a socket for the hip that's precisely aligned and corrects the deformity that existed before surgery. So this is very useful for helping us position the socket of the hip, not as much on the stem. On the femoral side and the stem side, it helps us match what's called the offset or the length and also the leg length, so it gives us hopefully optimal stability of the hip. So the robot helps us in those areas.
All right. What kind of recovery time are you looking at for something that we just saw right there?
So total hip replacements, in the past, typically they would stay 3 days in the hospital. They would sit there and be a walker for 2 weeks. It would take them 6 to 12 weeks for recovery. Now, with our approaches, whether you use the robotics through an anterior approach or posterior approach, you can now start the patients walking typically an hour after surgery. About 25% of our patients go home the same day. The rest of the patients go home the next day. Typically, for them to go home, they have to be able to walk. With a cane, they have to be able to go up and down steps, and that the stair climbing gives us functional stability and tells us the patients can stand to be alone by themselves for periods of time because they have balance and functional stability. So stairs are a useful indicator, and we discharge the patients. Again, the average patient, somewhere between 12 and 24 hours after surgery, they're discharged in a full weight-bearing mode.
All right. What are some things that we can do to keep our joints healthy?
Well, first thing always is stay in shape.
Yeah.
Always looking back at yourself and saying, how do I fitness? And fitness, again, revolves on keeping yourself flexible, keeping yourself aerobically conditioned. Studies suggest that you need 30 minutes of aerobic conditioning 5 to 6 days a week. You need to maintain that functional activity and tone. Obviously, keep weight down if we can. That's always a useful parameter. But even if you are heavy, if you maintain flexibility, maintain strength, you have the best chance of keeping yourself long-term with better functioning joints. Knees are more effective than hips in terms of that parameter. And then again, looking at your lifestyle. Avoid high impact loading, avoid aggressive loading, especially if you have pain or symptoms.
Okay. What about if we do get these replaced joints? How long do they normally last?
Well, in the past, they used to argue that at 10 years the joint would wear out. And mostly that was because the plastics that were used in the joint, the plastics of the socket or the plastics of the femur and tibia, that those would wear out over time. But now we have new what's called cross-linked polyethylenes, where the plastics have been specially annealed and treated with X-ray treatments so that they're much more durable. So at 1 year, the survivorship is somewhere between 98 and 99%. At 10 years, the survivorship is well over 90%. At 20 years now, estimates are over 80%. Some people are saying at 30 years, over 70% of joints can function. So we're now looking at a joint that someone in their 40s, 50s may have a joint that might last the rest of their lives if they look at it 80, 82 years as a life expectancy. So we're now getting to the point where we think if a well-implanted joint has the potential to last the rest of your life depending on your function and activity.
Yeah, that's very cool. All of these innovations that are coming around. It's very interesting tonight. Got a couple more questions here. Do supplements like glucosamine help with your joints?
Glucosamine was very popular. It's one of these nutraceuticals, and they were for a long time studied and used to make people feel better. They do help on an analgesic level, but prospective studies by the American Academy of Orthopedic Surgeons have not shown that they really affect long-term joint function. So I can't say that the nutraceuticals at this stage, such as glucosamine, chondroitin, and those type of nutraceuticals give you any long-term functional improvement, but they help with analgesia in certain patients. So if you feel better, you can take them, but don't expect them to increase the longevity of your joint.
Okay. Now we've talked a number of different things about injuries, things like that. Do people have joint problems just because of heredity?
Well, heredity is a major factor, and there's a large number of patients that are born with certain deformities. On the hip side of things, the most common is what's called dysplasia, or a shallow socket. So instead of the ball being seated very deep in the socket when you're born, it's seated shallow. That's dysplasia, so it's a shallow socket, and they tend to have premature arthritis. If we can find these patients early when they're still in the newborn period, treat them, we can avoid this disease. So there are ways to look at this, preventative treatments, but it is a hereditary issue. Dysplasia happens often bilateral and in family histories. On the knee side of things, yes, if you're born excessively bow-legged or excessively knock-kneed, or bow-legged, knock-kneed, and there's too much deformity, yes, you're abnormally loading the joint, so that can predispose you to wear. And I would argue that that is probably the most common cause for joints wearing. Activity, function, trauma, other things are also affecting that, weight, work, but many cases, in fact, I would argue the majority of cases, you have a genetic predisposition, unfortunately, and those are the patients that also should know early and try to maintain their function out of their joints. They're the ones that would benefit the most. And that's what we need to do in the future, is find these patients early, give them advice early so that they can get normal lifespans out of their knees and hips. So we're not talking about surgeries and ways we can help them.
There you go. Well, thank you so much for joining us tonight. It's been a pleasure talking to you. I can see your passion and your excitement and getting this information out to our viewers, so I appreciate your time tonight.
Thank you all. Thanks.
And thank you for calling in with your questions this evening for this live edition of Being Well. We will be posting this to YouTube, so if you have a friend or family member who missed this episode tonight, be sure to let them know that it's going to be on our YouTube channel. They can get to that at WEIU.net. I want to thank our partnership with Sarah Bush Lincoln. We appreciate your partnership. We appreciate Dr. Benuti being here this evening. We're sorry that Dr. Brewer wasn't able to join us, but maybe we'll be able to get him on next season. Once again, thank you for watching tonight, this episode of Being Well.
Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System.
At HS St. Anthony's Memorial Hospital, we are at work transforming heart care, rebuilding knees and hips, delivering new generations, and focused on providing health care to you. We are HS St. Anthony's Memorial Hospital.
Meeting the ever-changing healthcare needs of our communities, Paris Community Hospital Family Medical Center is now Horizon Health, with the same ownership, management, providers, and employees. Horizon Health provides patient care and promotes wellness to the communities of East Central Illinois.
Carl is redefining healthcare around you, innovating new solutions and offering all levels of care when and where you need it. Investing in technology and research to optimize healthcare, Carl, with Health Alliance, is always at the forefront to help you thrive.